So today's our topic will about history taking in exam abdominal examination. So when we start examining any patient, we have to know about him. Okay, so these are common things which you ask to each and every patient. Okay, so patient's name, his or her parents' name, age of the patient. Age is important because some gastrointestinal disorders are seen in younger children while others are seen in older children, like uh, cholestatic jaundice can be seen in infant, but we usually find Wilson's disease in patient of around 10 to 14 years or 15 years of age. Likewise, lymphoma also shows bimodal. Hodgkin's lymphoma also show bimodal age distribution. Okay, as well as cystic fibrosis can also be seen in the newborn or infant, and patient with hepatosplenomegaly due to thalassemia will present you at around 6 months of age or after first year of life. Okay, so sorry, race, cystic fibrosis is common in western or white or Caucasians, while some disorders are common in Indian. Usually address, some diseases are common in one geographical location whilst others are common in another geographical locations. So first we have to ask about the presenting complaint of the patient. We have to record about the presenting complaints in patient's language. We do not modify it, and we have to register these complaints in chronological order, which means the symptom which appear first, we should have to write down it first, then we move on to other symptoms which appear later on the stage. Now, history of the present illness. History of the present illness, we have to ask about the presenting complaints, and here also during writing history of present illness we follow that chronological order. We describe symptom which appear first, and we move on to these symptoms which appear later. We have to ask about the onset, whether it is acute or insidious. Okay, whether the complaint is whether the symptom is progressive, increasing in its intensity, or it is not progressing, remaining that static, or regressing. Are there any associated factor which leads to the aggravation of that symptom, or other factor which relieve it? There is any change in the symptom due to the day or night or day to day variation. Okay, now there are many symptoms which are associated with the abdominal illnesses. So these can be pain in abdomen, vomiting, nausea, retching. Retching is a strong involuntary effort to vomit. In this, vomiting does not occur, and effort are very strong. But in nausea, the patient usually feel unpleasant epigastric sensation. Okay, and patient can complain about increase in salivation, but the intense or strong effort to vomit will be not there. Regurgitation is a symptom in which the food particles return from our stomach to the mouth. Now patient can present with distension of the abdomen, patient can complete constipation. So constipation, we for clinical aspect we use constipation for difficult infrequent passage of stools. Okay, now another important abdominal symptom is diarrhea. Diarrhea is whether increase in frequency, fluidity or weight of the stool. If weight of the stool is more than 10 gram per kg per day, then it is can be classified as diarrhea. Now NCOP process, which means involuntary passage of a stool at inappropriate places after the age of 4 years. Before 4 years it is not called encopresis, but after 4 years it is encopresis, because usually around 3 years to 4 years child will tell you about he is having urge to pass a stool. Now hematemesis and rectal bleeding. So hematemesis is vomiting of blood, and rectal bleeding can be as hematochezia, in which fresh blood is passed, or it can be present as melena, which is passing of black tarry stool. Melena usually occurs due to the gastrointestinal bleeding above the duodenojejunal ligament, also known as ligament of Treitz, because if blood is arriving from above this ligament, then it is usually converted to the hemoglobin in this blood is converted into acid hematine due to the acid present inside our stomach. Now jaundice can be there, and pruritus can be seen if patient has hepatic failure or biliary obstruction. Now difficulty in swallowing can be there. Patient usually complained about the heartburn or burning sensation in the stomach. Now we move on to define these abdominal symptoms one by one. First one is pain in abdomen. So onset of pain can be acute or insidious. Now sight, we have to ask if child is old enough to tell about the location of the pain, then we have to ask about the site of pain. If patient can easily localize, he will point out at the site of the pain by his finger. So this will also help us in telling if something is wrong with that particular site. If patient is pointing towards the McBurney point, then he can have acute appendicitis. Okay. If patient is pointing at any iliac fossa, then abdominal pain can be due to the ureteric stone, or if patient is patient just use his hand and run over to the whole abdomen, then we know that pain is not localized and it can be due to colicky. It can be colicky or non-specific pain. Now radiation, we have to ask about the patient if pain radiates to any region. Usually in ureteric stone, the patient complained that pain starts from one iliac fossa or loin, and he is having radiation towards the scrotum and penis. So this can be there. or pain can be radiated towards the loin or backside in case of renal stones. Now, severity of pain, generally if patient have mild pain, then he will not having any discomfort, but if child is having severe pain, he may start crying or he will become restless. Okay, now timing and duration. If pain is associated, if pain increases after taking food, then it can be due to the gastric ulcer, or if pain occur after 2 to 3 hours of food, it can be due to the duodenal ulcer. Okay, now character of pain, it can be colicky. Colicky means patient complained of having episodes of pain which lasted for 10 to 20 minutes, then subside, then again started increase in severity, and for lasted once again for 10 to 20 minutes and is again stop. This is colicky pain. Colicky, another word which we can use is पेन मरोड़ के साथ दर्द उठना. Okay, now pain can be burning, which is due to the any ulcer or gastritis, burning in nature, जलन के साथ pain. Or can be stabbing. Stabbing pain can occur also. Is there any aggravating or relieving factor? We have to ask child or his parents that pain subside after taking any medication like any antacid. So it can be associated with gastritis or gastric ulcer. If pain subside after taking food, it can be due to gastric ulcer. Now another symptom is vomiting. Here we have to also ask about onset of vomiting. In pyloric stenosis, vomiting occur immediately after ingestion of food. Okay, but if obstruction is in distal part of intestine, it will not occur immediately after having food. In pyloric stenosis, we can also see a lump after taking food and peristaltic movement after taking milk. Okay, now number of episodes, whether occurring after each feed or not. Now type of vomiting, it can be bilious or non-bilious. If vomiting is bilious, which means bile is coming, then this tells us that obstruction is distal to the ampulla of Vater. Ampulla of Vater, where bile duct is open in the intestine. Or if it is non-bilious, then obstruction is proximal to the ampulla of Vater. Now vomiting can be projectile or non-projectile. Projectile vomiting is seen in idiopathic pyloric stenosis. Also in cases of raised intracranial pressure like head trauma or any tumor in the brain, it will lead to the projectile vomiting. So in case of raised intracranial pressure, other CNS features will also be there, like loss of consciousness, seizure, or blindness, or any other CNS feature or history of trauma. Now contents of vomiting. If undigested food particles are there, it can be due to gastric outlet obstruction. If bile is coming, then it is due to distal obstruction distal to the ampulla of Vater. If fecus is there, then it suggests distal intestinal obstruction or fistula between stomach and colon. If blood is there, then it may be due to gastritis or mucosal damage. Now, associated events: is vomiting associated with yellowish discoloration of skin? It can be seen in hepatitis. If there are loose stool, then it is due to the gastroenteritis. If there is burning micturition, it may be due to urinary tract infection, or it can be due to ureteric stone or renal stone. Pain in right iliac fossa or at around McBurney point, this is due to acute appendicitis. Okay, now another symptom is diarrhea. Here we have to ask about onset of diarrhea, whether it is acute or insidious. If diarrhea lasted for more than 14 days, it is called as persistent diarrhea. More than 6 weeks, it is chronic diarrhea, and causes of these can be different. Nature of stool and number of episodes. We have to ask about how many times patient has passed stool. Nature of stool, whether it is watery stool. Watery stool can be seen in secretory diarrhea or osmotic diarrhea. Rice water stool is seen in cholera. Okay, foul smelling stool is seen in fat malabsorption, and blood in stool can be seen in dysentery due to E. coli, Shigella, or it can also seen in the ulcerative colitis. Now, type of food taken. Some patient have allergy to some foods, or patient may have taken some poisonous food, or it can be due to food poisoning due to now time interval between food intake and onset of event. In case of staph food poisoning, we can see diarrhea after 2 to 3 hours of taking food. Another symptom is constipation. Onset: if it is since birth, it can be due to hypothyroidism or intestinal obstruction, or can also be seen as imperforated anus. Now, whether flatus is passed along with stool or not. If flatus is passed, then it is known as constipation. But if stool as well as flatus both are not passing, then it is known as obstipation. Now, frequency of stool: some child may pass stool once in 2 days, and this can be normal. Okay. Now, altered consistency of stools. Patient may pass hard stool, okay, dry stools. For this consistency of stools, there is a chart known as Bristol's chart, which is in which different type of consistency of stool is given, and parent has to point out which type of stool is patient passing. Now, difficulty in passing stool. This can be due to because the patient has not yet been trained for toilet training, or there was no toilet training at all. Okay. Now, pain during defecation. This may be due to any fissure or fistula or around anus or perianal fistula. So we have, or anal fissure. Associated symptoms like in hypothyroidism we see uh, um, intolerance to cold and developmental delay. Now abdominal distension, it if sudden in onset, it can be seen as congestive cardiac failure and Budd-Chiari syndrome. Insidious can be due to cirrhosis or decompensated cirrhosis or tuberculosis. Now duration, and if it is progressive, static or regressive, we have to ask about this. Was there any preceding event, like patient has diarrhea, then this abdominal distension can be due to excessive potassium loss in the stool. Abdominal distension can be due to hypokalemia, due to excessive diarrhea. So we have to always ask about the any preceding event. Is there constipation? Patient is not passing stool, then he can present with abdominal distension. And anorexia, okay, associated, whether it is associated with fever or pain in the abdomen. Now another is jaundice. Sudden onset or jaundice is seen in obstructive jaundice. Insidious onset is seen in hepatitis. Patient with severe anemia can also present with jaundice, like in sickle cell or thalassemia, because of hemolysis. Now duration, this is important, whether jaundice is of chronic in nature or acute. Chronic can be seen in cirrhosis, Wilson's disease. Acute can be acute infective hepatitis. Associated features are if patient is passing clay colored stool, having intense pruritus. These two things are seen in obstructive jaundice. Now gastrointestinal bleed, if vomiting, blood in vomiting is seen, then it is known as hematemesis. This can be due to esophageal varices. If patient is passing black tarry stools, then this is known as melena. This is due to the bleeding above the ligament of Treitz. And if around 50 to 100 ml blood is uh, bleeding around 50 to 100 ml, only this amount of bleeding will lead to melena, not less than this. And blood has to stay in our intestine for around 6 hours to convert in the acid hematin. Now hematochezia, this is frank blood. If frank blood is passes from rectum, this is called as hematochezia. This is due to lower GI bleeding, and it can be due to hemorrhoids. Now other extra abdominal features which suggest gastrointestinal disorders are whether patient have history of any skin change, like in malnutrition we can see flaky patodermatosis. Patient is having itching or purpura, which is seen in obstructive jaundice. Any perianal excoriation, which is seen in lactose intolerance, whether secondary or primary, and in acrodermatitis enteropathica. Any history of difficulty in breathing, palpitation, chest pain, this is seen in congestive cardiac failure. Is there loss of hepatitis seen in viral hepatitis? We have to also check for malnutrition, for SAM, for malabsorptive disorders. associated CNS features which can seen in Wilson's disease. Is there any altered sensorium or seizures? This will be seen in hepatic encephalopathy. Any joint pain or arthritis. These arthritis are associated with inflammatory bowel diseases like Crohn's also associated with uveitis and episcleritis. And erythema nodosum is also seen in Crohn's and ulcerative colitis. Patients can also have Bitort's spot due to cholestatic jaundice or malabsorption syndrome. These are extra abdominal features seen in gastrointestinal disorders. Now another part we have to ask about any past illness like jaundice, whether patient have jaundice or not in the past. Previous gastrointestinal bleed. Recurrent bleeds suggest there is portal hypertension and impending liver damage can occur. Now passing of worms in stool. Many times worms leads to the pain in abdomen. Any history of tuberculosis, any history of blood transfusion or needle blood transfusion history is important due to the passage of CMV and hepatitis B through the blood to the patient, which both of these can lead to hepatitis and hepatic cirrhosis. Any history of sepsis or previous history of any surgery or hospitalization. Now another important point is treatment history. Most of the time patient is having drugs which leads to the hepatic failure, like antibiotic erythromycin causes hepatic dysfunction, antiepileptic like phenytoin and valproate causes, anti-tubercular drug especially INH causes hepatic dysfunction. So many times we ask if whether patient has any history of TB or taking any ATT, but the point we miss out is that patient does not have any TB, but his family member will have TB and taking treatment for the same. So in this case INH prophylaxis is given to the children, and we have to specifically ask for history of ATT in family, because patient may present with hepatic failure, and the cause of this hepatic failure is only INH prophylaxis. Now antipyretic drug paracetamol, which is most common drug which leads to the hepatic failure. Sulfonamide, anesthetic agents like halothane also leads to the hepatic injury. Now history of blood transfusion we have to always ask, because thalassemia can also present as in hepatosplenomegaly, and patient have cirrhosis, and due to the blood transfusion related hepatitis B. Now another important is antenatal history. We have to ask about torch infections in mother and immunization of mother, history of any drug intake in mother. Now neonatal history, whether patient has low birth weight or jaundice or kernicterus. Okay, this can lead to autoimmune hepatitis or extrahepatic biliary atresia. Now developmental history, many storage disorders are associated with developmental delay and hepatosplenomegaly. Now nutritional history, malnutrition will lead to the diarrhea, and malabsorption will lead to malnutrition and chronic diarrhea. Also, chronic liver disorder may lead to the malnutrition. Now, family history, we have to ask about consanguineous marriage in the family, because it will increase the chances of autosomal recessive disorders like cystic fibrosis, mucopolysaccharidosis, and Niemann-Pick disease, Hunter's disease, Gaucher's disease, any history of jaundice in the family like hepatitis, any history of chronic liver disorder in the family, or any history of chronic cough. Chronic cough can be due to alpha 1 antitrypsin deficiency, which also leads to the hepatic failure in the child. Now, socioeconomic history. This is important because many in low socioeconomic groups we found there are many infections like hepatitis, and due to poor sanitization and bad quality of water, patient can have amoebiasis, chronic diarrhea, or persistent diarrhea. So this will sum up about history taking in the gastrointestinal examination. Thank you.